Hello, everyone. Thank you. First of all, thank you for joining us for this webinar titled COVID-19, What We Know and What We Don't Know and Why This Matters. This is being hosted by the BRAC James P. Grant School of Public Health, BRAC University. Today we have with us as our panel speaker, Dr. Michael Friedman. He is the Country Director for the Center for Disease Control and Prevention, CDC. And I must mention that Dr. Michael Friedman, he's working from Bangladesh right now, and he did not go back to the USA during this crisis. And this webinar will be moderated by Professor Kausar Afsana, who is from the BRAC James P. Grant School of Public Health. Michael will give a brief presentation, and after the presentation is over, we will open up the webinar for any questions and discussions that you might have. So our viewers and participants, I would encourage you to ask questions through the chat box that we have on Zoom. And I guess we're ready to begin. So Professor Kausar Afsana, Michael, if you could please start the presentation.
Hi, thank you so much. And we actually welcome everyone to our session and webinar session today. And we are very delighted to have Michael Friedman. He is an expert in infectious disease and how he's role in COVID-19 crisis in Bangladesh. So let's start with Michael Friedman. Michael, floor is yours now.
Okay, good afternoon, everyone, and I hope you all can hear me okay. If you can't, just raise your hand. No, I'm just kidding. You won't be able to see that on this webinar, but I'm thankful to the group, to the BRAC School of Public Health, to inviting me to give this talk. I hope it's informative for everyone, and leads us to think a little bit more deeply about this crisis that we're in the middle of. In any crisis, I think the challenge is that we're so busy fighting the immediate fire in front of us that we don't always have a chance to think about the big picture and what's happening all around us. So this is hopefully a chance for us to think a little bit more about the big picture of this, and try to think of long-term and short-term solutions. So I'll get started. My presentation is about 20 minutes long. I apologize, there's a lot of information on these slides, which I don't think we're going to cover all of it in 20 minutes. So I will pick the highlights, and hopefully the slides will be available on the webcast or in some other way afterwards that you can look at some of the more of the details if those out there want to. So let's go to the first slide. The next slide.
Robhai, if you could please go to the next slide, please.
I guess Robhai can't hear.
I guess we're having some, yes, I guess we're just having some technical difficulties. If everyone could just please bear with us for a few minutes.
Anyway, without the slides, I can kind of get started.
I already shared
these slides.
Can you share? Can you see the file?
We can only see the title screen. We cannot see the.
Yeah, then it is the file.
Yes, please go to the next slide. Thank you.
Yes, great. Thank you. Okay, so to get started here, this is just a slide of. No, go back one. Sorry. No, please go to this. Go to the second slide, the map.
This one.
Yes.
There we go. Okay, and I'll just say next after the next slide. So let's just start with this one. So this is just a quick overview of where we are globally in terms of cases. This map is updated, of course, daily, and things are always changing. But you can see this is truly. You can be. Sorry, you can see here. This is truly a pandemic where it's spread really basically across the entire globe, and some places have been harder hit than others, and we'll talk a little bit about that a little bit later in the presentation. Next slide. So I'm going to start with a little bit of the clinical picture with this thing, and then we're going to move into some of the public health aspects of this. So many of you know already, but just for those of you that don't, that the vast majority of patients that get this this virus have either mild infections or completely asymptomatic infections. And the number that's been thrown around is about 80%. About 4 out of every 5 patients that get it will have either mild symptoms or asymptomatic. It could even be higher than that at the end of the day. And then therefore about 15 or 20% of patients will end up having some more severe illness that requires significant, maybe some degree of medical attention, significant or not. Next slide. Let's go to the next slide, please. Thank you. So the key right now in terms of thinking about this is, of course, the morbidity and mortality associated with this virus. I mean, a virus that spreads around the world is one thing. A virus that spreads around the world and causes a lot of morbidity and mortality is another thing. So for a second, let's focus on that a little bit more and understand, who's really at most at risk for this virus in terms of, again, in terms of morbidity and mortality. And if you look at this, you can see from these numbers that the vast majority of the risk is in older populations. Really above the age of 60, you start to see significant risk factors for death. 3.6% above from age 60, and then it goes all the way up above the 80 age group up to 15% risk. And I think it's very important to note that globally, the death rate among the younger group, let's say the age 10, and in this graph, it's we lump it all together between the age of 10 and 39, is really right here represented at 0.2%. That means about 2 per 1,000 patients in this age group may end up dying. And I would say that the number actually is probably much lower than that in that age group. 0.2% is what we found in this one data set of 72,000 patients. But we're finding overall, if you look at these numbers from other countries, from Italy, from the US and others, we're finding that the death rate in this age group between 10 and 39 is actually probably closer to 0.1% or maybe even lower than that. So we're talking about a relatively low mortality among young people. And that's very important to remember when we think about the implications of this disease. Also remember, please also remember that it's not just age, but it's also other health risk factors that are very important in terms of this disease. So cardiovascular disease, high blood pressure, diabetes, and obesity, and known chronic respiratory disease are the ones that we most are looking at most closely and the ones that are most associated with having a bad outcome. Next slide. Sorry, let's go to the next slide.
Please put a mute on your microphone. Can the ones who are not talking just mute their microphones, please?
Okay, so go on here. You can see here that the death rate again on the left part of the slide shows that it's much higher among those with cardiovascular disease or diabetes or hypertension, anywhere from 6 to 10% rate of death rates. But if you have none of these factors, your death rate is under 1% for sure. So even if you're an older population and you don't have any of these risk factors, the outcomes are much better. So it's a combination of age and it's a combination of having these underlying issues. Even in young people, if we start looking at young people, a vast majority of the young people that have had severe disease or severe outcomes, hospitalizations or death or any of those bad outcomes, are mostly people that have had some other health issue beyond just COVID. So the message here is that, you know, a significant part of our population does have these issues, these risk factors. But if you happen to be one of those people that is healthy and under the age of, say, 50, the risk is actually very low in terms of this disease compared to many other things. So it's something just to remember. Next slide. Next slide, please.
Victor, next slide, Corbin, please. I think we're a bit frozen, yeah.
Okay. So this slide just looks at some of the predictors of having progressive disease. And again, I don't want to go through the details of this. Some of these are blood tests, some of these are X-ray findings, and other comorbidities, things I've just talked about. This may be important in terms of predicting who needs to be in the hospital and who can be treated at home. So again, I'm not going to go through the details of this, but know from a public health standpoint, this is very important because it allows us to stratify patients that are tested and positive into, you know, who should be in home therapy and who actually needs a hospital bed. So next slide. Okay. So turning away attention a little bit from the issue about treatment, about you know, the medical prognosis and risk factors, just talking a little bit more about how the disease is actually spread. So many of you know that this coronavirus, our understanding of how it spreads has evolved over time. So, you know, the initial reports out of China in the first few weeks were that disease is not even spread person to person.
Can I get everyone joining? Sorry, Michael. Everyone joined on Zoom, can you please mute your microphones? That will help with the lessening the echo. Can I request you to please, or can you mute it as the host, Rauf or Rafi? Can you mute everyone's microphone? Who's the host? We are. Can we mute?
No,
sorry, Mike.
no, we cannot mute it. So everyone, can you please mute your microphones except the moderator and Kasra, except the ones that are talking us. Please mute your microphones.
Okay. Sorry, Michael. Please continue.
The host can mute everyone. It is an option available.
Okay, so we're gonna figure that out, Michael, while you speak. Okay, continue.
Okay, anyway, we're learning as we go along, just like we are in this pandemic. So in terms of understanding the spread of this disease, I was saying that this has changed over the course of the outbreak in terms of our understanding of it. But the general overall feeling still hasn't changed very much. And that is that this is a disease that spreads similar to the way influenza spreads, which is mainly through large infectious droplets, okay? And that means that you basically spread it by touch, okay? Using your hands, your nose, you may have a cough, you may use your hands to cover your face, and when you're coughing, you may sneeze into your hands, or you know, you might have a runny nose and touch your nose, okay? Your hands are now infected. You go around, you touch something and someone else touches it, okay? They have their hands now contaminated and they may scratch their face or touch their mouth or bite their fingernails or whatever, and then that's how transmission happens, okay? So this is a typical route in how viruses spread. There's also the possibility that you can breathe it in. You can breathe it in if you're close enough to people, okay? And this was controversial in the early parts of the pandemic, and I think as time has gone on, we've realized that this is definitely possible. However, this does not mean that we have wide-scale infection droplets in the air all around us, okay? Like this slide here demonstrates, we have large infectious droplets, we have small infectious droplets, and we have infectious droplet nuclei. The last one is the last one is not happening here. in terms of this. And that it really is mostly large infectious droplets. So that means that if we can keep our distance from people, okay, within 1 to 3 feet specifically, but sometimes we may say, okay, even to be safe, 3 to 5 feet from people, that's really going to be make a significant difference in terms of trying to prevent the spread. And if you cannot keep this kind of distance, say you're on an airplane or you're in a vehicle or some other place where things are crowded, a market, then wearing a mask will make a difference. And so this is a very important aspect. But I will like to emphasize that this does not preclude the idea that you need to wash your hands. We still think that a vast majority of the virus is being spread by touch and by people not washing their hands and practicing good hygiene. So we have both of these that are very important. Okay, next slide.
Rohbhai, next slide, please.
Great. So this slide here just talks, this is just a little bit of a comparison between seasonal flu and COVID-19. And because I think the flu is probably the disease that's closest to influenza, influenza is the disease that's closest to COVID in terms of our general public health understanding, okay? There are some differences which we want to go through. One is that the RO, which is the number of people that will be infected from any one person who gets it, is higher for COVID. It's around 2 to 2.5, but it varies, of course, by the situation. Whereas flu, it's only 1.3. So that means that it spreads a little bit easier, COVID does, than influenza does. And we know influenza actually is pretty contagious. Second thing is incubation time. The influenza actually has a very short incubation period, which means that's one of the reasons why influenza spreads so quickly around the world in the winter time, especially. Whereas in COVID-19, the incubation period can also be short, but it also can be quite extended. So we have a much broader, longer incubation time of 1 to 14 days. Hospitalization rate, like I mentioned, for influenza is only about 2%. Whereas hospitalization rate for COVID, when we looked at our early data, was about 19%. Of course, we think now that more data is coming in and we understand there are more asymptomatic cases, the hospitalization rate is probably going to drop much lower than 19%, probably closer to 5 to 10% when we consider all the asymptomatic mild cases that haven't been tested that are actually having the disease. So the hospitalization rate between the two is definitely higher for COVID, but not that much higher. And same thing with the case fatality rate. Right now, it looks like there's a big difference, right? 0.1% versus 1 to 3.4%. But again, if we really factor in the idea that there's a lot of cases of COVID that are happening, that are mild, that are not being tested, then our case fatality rate would drop. And it's more likely that our case fatality rate is going to end up being less than 1% globally. And if it's less than 1%, the difference between that and influenza is there. I mean, there is a significant difference, but it's probably going to be maybe 5, maybe up to 10 times as much more dangerous than influenza is, but not 50 or 100 times more dangerous than influenza. So next slide. Great. So, and a few other factors about when comparing the two diseases. Can you get asymptomatic or pre-symptomatic spread? The answer is yes for both diseases. Can you get it from droplets and other ways of spreading it? Yes. Is it more severe in the elderly? Yes, and for both. Is it more severe in pregnancy? The answer for influenza is yes, but for COVID so far, the answer has been no. And the same with children. Is influenza more challenging for children who have underlying health issues or other things? Influenza, the answer is yes. But for COVID, the answer so far is that kids, even kids that have underlying health problems, the vast majority of them do fine with this. So the answer so far has been no. Of course, we're still learning more about this disease as we go on. Next slide. So this is a summary now of a little bit of what we know and what we don't know. And this slide particularly talks about what we do know. So this is a little bit of a summary of what I've just said. First of all, COVID-19 is very contagious. We know that now for sure. And we know it's more contagious 1 to 3 days before illness begins and over the first few days of the illness than it is later in illness. And this is very different than, say, for example, like SARS or Ebola, where the longer you're ill, the closer you get to severe disease and death, the higher the contagiousness. For this disease, like influenza, the contagiousness is mostly early in the disease before you show symptoms. So this makes it a little bit more problematic in terms of controlling it, okay? Number two is we have many young people and children get COVID, but do not show any symptoms or show very mild URI symptoms. This is something we now know, and it's definitely true. Those over the age of 30 are at some risk for severe disease and perhaps death. We know that the major predictors of severe disease are age and comorbidities, and those between the age of 30 to 50 without comorbidities are fairly low risk, but not zero risk. So in that age group, it's kind of like you need to be careful, but it's certainly not a hugely serious or high risk disease to get in that age group. And major clinical symptoms are fever, cough, flu-like illness. For those that do progress, you end up with a bilateral pneumonia with hypoxia, and illness can last for a long time. It can be up to 1 to 4 weeks. We know that the vast majority of patients that do get sick tend to get sick in the second week of illness. Well, the first week of illness tends to be a little bit more mild. They have like a flu-like illness. And it's the second and the third week in which the lungs and other organs start to really get impacted. Our understanding of this disease is increasing. We know that there is an immune response aspect to this disease. So after the initial infection, people get a hyperimmune response, which causes some of the damage in the lungs and in other organs. We're learning now that the disease is starting to also have effect on blood vessels, which increases the risk of getting strokes or increasing the risk of getting clots in your veins. So these are some other aspects of this disease that we're starting to understand and learn about. So these are all things that we now know or are beginning to understand. Next slide. Okay. Now getting into the other part of this this talk here, this last couple of slides are really talking about what we don't know. And this is really important. It's always important when you're dealing with a new disease and a new health crisis to think about not just what you know, but also really start thinking what don't we know and what do we need to know, because that will help frame the development of better science. It will help us also frame our public health responses overall. So one thing we don't know is why some people get sick and others do not. Like many diseases, not just this disease, whether it's meningitis, Japanese encephalitis, many other diseases that we have, you have two different people, one will get exposed, both of them will get exposed, someone will get meningitis, someone will not. And why is that true? It's the same thing here with COVID. We're not really sure why some people are more susceptible to this in terms of getting ill. And that's a mystery, not just for this virus, but for many viruses. Secondly, why children and young adults are relatively safe. This is a mystery so far. Why are we not seeing severe disease in younger people? This is a good thing overall, right? I think most of us would be very happy to know that our children and younger adults are generally safe, but we don't really understand why. What is it about their immune system that's protecting them as opposed to older people? Third, does having this disease once, meaning that if, say, for example, if you had a serology test that showed IgM or IgG positivity, does that provide long-term immunity? This is a question that we still don't really know the answer to. For most viruses, the answer is yes. But there are some viruses and diseases where if you get it once, you can still get it again. And that is a big unknown here. Partly it may be because if you are able to get it again, it might be because the virus changes, or that there's different types of the same virus circulating so that you can get a different type of that virus. So there's a lot of these kind of questions that we don't really know. But many people have speculated that once you get this once, we're probably going to have some type of immunity. And that's just basically because we know for most viruses that's true. And so we're just going on basically historical when we say that. And then the last question here on this slide is, why has the virus spread so rapidly in places like Wuhan, Italy, Spain, Iran, parts of the US like New York? But really, we have not seen rapid spread in some countries, like Vietnam, Taiwan. Singapore has had some spread, but they've been able to control it to some degree. Thailand, again, the same thing. Japan, the UAE, there are a number of these countries, mostly in Asia, but also some countries in other parts of the world where the spread has not been so fast and so great. So what is it about these places that the virus doesn't seem to be picking up as much? Is it simply just the lack of testing in these places? Is it just simply that there is disease, they're just not picking it up? The answer to that probably is no, because in many of these places, we have done a lot of aggressive testing. Even in a country like Vietnam, where there's only 270 reported cases, they've tested over 200,000 people. So we know that they've actually done a pretty good job of testing, they're just not finding it. So that may not be necessarily the reason. Is it effective hygiene practices and social distancing? Certainly that's a good reason. That's definitely a possibility why it's not spreading. They're really just are disciplined and following the general rules that we've set out to kind of prevent this disease from spreading. Is it a warmer weather? Well, there's been a lot of speculation about the weather and whether or not it's going to have an impact on this virus. There is a little bit of evidence that the virus doesn't last as long in warm environments, in the environment, like on doorknobs or on tables when it's hot and humid out. But I will say that that can only protect you to some degree, right? That because the viruses, even in a hot weather, are still going to be there if you have close contact with people. So maybe the warm weather is having some impact, but we don't think it's having enough of an impact that alone that's the reason why the virus isn't spreading. Okay. Is there some type of pre-existing immunity or genetic factors that prevent the virus from spreading in some places and not others? That's certainly possible. We do not know that information right now. We just don't know. And is there a change in the virus itself? Is the virus mutating? And in some countries, the strain is just more contagious. And in other countries, the strain is less contagious. This is a possibility, but we don't have any evidence of that so far. So the next slide, please. And another question that we don't know is to what degree do children and young adults are driving the spread of this virus across communities and in different cities. So basically, how effective are asymptomatic children and young adults, and how big of a factor is that in driving this? And that question has not fully been answered yet, but we're getting more and more evidence that suggests that this is an important part of the spread of this disease, that this asymptomatic carriers that are not showing many symptoms and going around infecting others is definitely part of the reason. And one way we know this from a lot of different studies so far and anecdotes, but we also know it from one modeling study from Wuhan that I'm just going to highlight here, where they estimated that 86% of infections in China prior to January 23rd, when the happened, prior to January 23rd, when the Wuhan travel ban was happened. And these were undocumented and untested infections. So a very high rate of what we call undocumented or untested infections. In this modeling, they estimated, and this was just a pure estimate, that undocumented cases were only 55% as efficient in transmitting the virus compared to tested or sick people. And the idea being that if you're sick and you're coughing and you're sneezing and you're having a fever, that more likely that you're transmitting the disease. You have a higher viral load and you'll be spreading it more compared to people that are asymptomatic. So this was a reasonable assumption. Even though the 55% number, I don't know where that number actually came from. However, since undocumented cases were so high, there were 86% of all the cases, the study estimated that 80% of the overall spread in China before January 23rd may have been due to unidentified cases. So basically what this modeling study was suggesting was that, it wasn't the sick people going to the hospital that was spreading the disease as much as it was all the undocumented cases that were in the community having mild symptoms that people were not really caring about and worried about, and they let their guard down. Because of this type of understanding now of this disease is one of the reasons why all this social distancing and closing down workplaces, closing down public buses, places like that. This is one reason why all of those things were implemented, was because of this kind of understanding or this belief that is this group of people that we don't really even know that may be transmitting the disease. And so that is driving policy now. Our evidence of this is there for sure. I think as now time has gone on and now we're at the end of April, we're starting to understand that this is probably very much true. But a month ago, 2 months ago, we weren't really so sure of this. But it's becoming more and more true. And one of the reasons why we're at this stage. Next. Okay, another thing that we do not know yet is the true case fatality rate. There's been a lot of media attention on this, especially in the US. And the reason why it's so important is because the fatality rate will drive policy. I mean, a disease that is killing a large number of people and has a high fatality rate is going to be taken a lot more seriously than a disease that has a lower case fatality rate. That makes obviously a lot of sense. And so this is really an important question that helps drive public policy, especially when you're talking about all the economic and social difficulties of controlling this disease. People say, well, what's the gain from doing all those things in terms of saving lives? So we need to know what the true case fatality rate. To do that, we need to know the numerator and the denominator. The numerator being the true number of deaths and the denominator being the true number of cases, okay? So for Bangladesh, this is challenging. For the world, this has been challenging, but in Bangladesh it's challenging because number one, that many deaths may not be recorded or tested. So we may be underestimating the number of deaths that we're having in Bangladesh. And for the denominator, the number of true cases, we know that not everyone is getting tested. We know that our testing rates in Bangladesh are not that high. And to give you an example, this is not new for COVID. This is not to say that our efforts in COVID have been poor. It's just the reality of this disease and really any infectious disease. We know that for dengue, typhoid, cholera, hepatitis B, they all have much higher prevalence estimates than the actual number of people tested. So what I mean by that is that if you do serologic testing or testing of populations, you'll find that, for example, in dengue, 25% of all people living in Dhaka have had evidence of dengue infection, right? But if you count the number of actual dengue cases per year, that number is much, much smaller, much, much smaller. So it means that we have a lot of cases happening in the community that are never getting tested. And the same is true probably for COVID, okay? And some diseases like JE and hepatitis A, Japanese encephalitis, they have a very large percentage of asymptomatic or mildly symptomatic cases that never get diagnosed, right? So when we say, oh, the incidence of these diseases is not very high because we don't have that many cases coming in, we're really underestimating the actual true number of these cases of the disease because there's so many people that actually were exposed to the disease. They just had a very mild or asymptomatic disease. And so that factors into our public health response to these type of diseases. So for hepatitis A, for example, most people in Bangladesh get it at a young age. It's a very mild disease at a young age. In fact, it's a lot of asymptomatic cases. And therefore, a country like Bangladesh has not implemented hepatitis A vaccination yet of the population, okay? So they do that because so many people are getting it at a young age when it's a very mild disease, they feel like there's no real need for it. However, in other countries where the hygiene practices are better and people don't get hepatitis A until they're older, and then there's more symptomatic and severe cases, the feeling is that we need to implement the vaccine. And so that's just an example from hepatitis A, and we can use that analogy for thinking about COVID as well. Okay. Finally, I'll say here, in places where serosurveys for COVID have been done, the number of estimated cases can be as much as 10 to 30 times the number of positives that have been tested in those countries. Okay. And if that's true, if we believe that, then that would cut the case fatality rates to probably less than 0.5%. So right now, you know, globally, we're finding about a 3%, 3.5% death rate based on the number of people officially tested and positive, and the number of people officially tested that have died. Okay, so it comes out to about 3 to 4% around the world. But if we actually looked at the true number of people that were actually probably got the disease, and we thought that that number was much, much higher than the number of the people that were actually being tested, the case fatality would drop at least probably 10 times to 10% of that number, which would be, say, instead of 3.5%, it would only be 0.35%. So that's a huge difference in terms of our understanding or public decision-making process. So this whole issue is something that's very, very important, and we need to better understand. Next slide.
Ruth, next slide, please. Michael,
So,
sorry, I was just going to come in. We've got about 5 minutes because we've got lots of questions. I know you're towards the end.
Yes.
And they're really helpful.
We're at the end of the thing, so I'll just quickly go through these last couple of slides.
Thank you.
So this slide just quickly is just looking at this disease compared to other important diseases over our history, our human history, in terms of where they are. And you can see that we're looking at the fatality rate on the vertical axis and the average number of infected per sick person on the horizontal axis on the bottom. And you can see here that the most deadly disease that we've probably faced that also is highly infectious is smallpox. Okay, smallpox is a disease that had a very high fatality rate, but was also highly infectious. Fortunately, we've eliminated that from the world, so that's a really positive thing. You can see some other diseases like Ebola have a high fatality rate, but they weren't that infectious, and we were able to then control it. Okay, so this disease, and the other one on this graph that I think is worth mentioning is measles. Measles is a disease that has very, very highly infectious and had some death rate. So it was a very important public health problem. And again, because of vaccination, we've controlled measles and we've gotten that number down a lot. So these are good examples of other public health challenges that we've faced. For this disease, it's in this box here. And you can see here for coronavirus, we don't really know exactly where in this box it is. If the death rate is closer to 0.1% overall, then it's at the bottom of that box. And if the death rate is closer to 2.5%, then it's at the top of that box. So you can see here that knowing the death rate would affect where this disease sits compared to other important public health diseases throughout history. Next slide. So what do we know about, what we also don't know is about therapeutics and the use of ventilation or ventilators, okay? So we have 3 questions here that I'm not gonna go into too much detail here on, but just to mention that we don't know the answer to, and it's very, very important in terms of understanding our overall response to this, this pandemic. One is, can any medication prevent infection if taken daily, such as we have for HIV, malaria, and influenza? So we use it a lot for malaria, as people know when they travel to malaria endemic areas. But you may not realize that for HIV, for very high-risk people, we can give HIV medicines to prevent HIV in those high-risk people. We also can do the same for influenza. We can give influenza meds to people like in nursing homes if there's an outbreak to prevent those people from getting influenza. So we do have other diseases where this approach has been taken. But for COVID, we don't know the answer to this yet. The second question is, what are the most effective ways to prevent severe disease if one is early in the infection, but at high risk for hospitalization and death? So say you're 60 years old, you have diabetes, you're obese, and you have hypertension, right? It's a pretty risky situation. Is there any medications that would limit or lower the risk in you? And that question has not been answered. Of course, there's been a lot of interest in this hydroxychloroquine, but there are other drugs listed here that are actually also very important that we're looking at. And right now, the answer is we don't know. We don't have the trials done yet to know if any of these drugs are actually going to be effective or not. And this is a very important question. Third thing here is, what are the most effective ways to treat severely ill patients that have hypoxia or ARDS? And there's a number of things listed here. I'm not going to go through the details of these drugs, but they are showing some promise. And if we can find these drugs that work and get them available throughout the world, this would also change our approach to this disease and understanding. So these are very important issues. And the last thing here is the issue about how best to manage a hypoxic patient. And there's a lot of controversy right now about the use of ventilators versus CPAP versus just giving oxygen alone. And we don't have any good scientific data to understand exactly what the right rational approach should be in terms of these patients with hypoxia. So next slide. The last thing I want to talk about here is flattening the curve. You've heard this term a lot. Here's a depiction of what flattening the curve actually is. Basically, it means we spread out the infections over time. But it means the total number of infections is still the same, okay? So that's the most important thing that people get wrong in this, okay? Flattening the curve does not mean reducing transmission and reducing disease. It means spreading it out over time. Next slide. Okay, so can efforts to flatten the curve in Bangladesh really work to drastically slow down the spread of the virus? So this is something we do not know the answer to, right? Is total lockdown the only option that can work here? Okay, what other less dramatic options are there, and can they be enforced? So these are really important questions that we can speculate on and we can talk about, but we don't really know the answer to those questions right now. Number two is, what are the long-standing benefits of flattening the curve? Okay, so we think that there might be some benefits, right? Number one, if we flatten the curve, slow things down, if vaccines arrive early, then that's great. Then we've saved people from getting this disease, okay? Or if we find a low-cost drug or multiple drugs that reduce the disease severity, by flattening the curve and reducing the number of infections early, we can now use these drugs, okay? And third, we buy time to improve hospital services like oxygen, ventilators, things like that. So there are some theoretical benefits to flattening the curve, but the question that we don't know is, are any of these three things actually going to happen, right? So that's why it's in the we do not know category. The third thing is, what are the short-term and long-term costs of flattening the curve in a lower middle income country such as Bangladesh? What are the economic, social, and educational impacts of trying to flatten the curve? Okay, we can talk a long time about that, but that is a hugely important question that we need to be asking and thinking about. Okay, and what are the impacts on other public health services such as immunizations and tuberculosis control and other disease control issues? If we spend so much energy trying to flatten the curve for coronavirus, are we just creating the opportunity for a new TB epidemic or a measles outbreak or some other issue? So this is another hugely important question. Next slide. Okay, so there's a lot of questions here, and this is just a quick slide to summarize some of this and to say what direction we should take a little bit. So here we say a couple of key points here. One is that preparedness is the key to blunting the impact of a pandemic. So countries that were more prepared for this have done a better job so far. And countries that have a strong public health system also have slowed down the spread of this disease better than countries that don't have a good public health system. And the last thing I'll say in terms of this is that having a strong and equitable clinical health systems should help lower mortality rates. Again, we don't know that for sure, but that's an assumption that we believe. Second thing is we should detect the virus early and search aggressively for cases in clusters. This idea that you can't fight the virus if you don't know where it is. So I think the world has taken this very seriously, and we're trying to do this. So increasing the ability to test. The third thing is to reduce the transmission of the disease. We want consistent hygiene practices for everyone. We want to practice social distancing. And thirdly, but very importantly, we want to limit travel, especially across districts, because if there are some districts that are more hit than others, then having people travel a lot across these districts is only going to increase the spread of this virus within Bangladesh. Innovation is very important. We have to come up with innovative ways to protect the elderly. So how do we do that in households that have multi-generational households? It's very challenging. How do we use triage processes and other processes to keep health services operating effectively and efficiently beyond just COVID? So these are areas that we need innovation for. And finally, we need resource mobilization, right? You cannot fight a pandemic like this without funds, without equipment, and without people. You need all of those things. Next slide. We need to mobilize different stakeholders as listed here, and we need to develop an effective and detailed response strategy action plan. Part of that is to develop working groups that can meet of experts that can deal and not only make guidelines, but they can also review the progress that we're making in each of these areas. Because one of the key things with any outbreak or any long-term health issue is you have to constantly reevaluate the situation. So just because you make a decision today doesn't mean 2 weeks from now that we shouldn't be re-looking at that, saying, what did we do right? What's going well? What's not going well? So that constant process has to happen. And you need to divide up the leadership in a way that each group can be tackling different aspects of the crisis. This is basic crisis management practices. Next slide. Okay, and this is the last slide. Basically, it's saying that we also have to be smart. We have to think medium term, not just short term. Everyone's focused on the next month, but we need to be thinking the next 6 to 18 months for this disease. And that's a different level of thinking. We need to learn from other countries. We need to adapt global strategies to the Bangladesh context. So not just take what America's doing or what China's done, but think about it, how can we do that in Bangladesh? We need to keep up with the evolving science of COVID. Every day there's new information coming out, so we have to have teams that are constantly looking at this science and updating policymakers. And we need to use epi data and science to make key decisions. We need randomized controlled trials for vaccines, drugs, medical interventions. We need cohort studies to understand risk behaviors. We need serosurveys to understand the true disease prevalence and the case fatality rate. So I'll stop here. These are just some of the things that we are focusing on here at CDC and trying to help in any way we can. So thank you.
Thank you so much, Michael. Dr. Michael, for your presentation. Dr. Afsana, are you still with us?
Yes.
Professor Afsana, are you there? Okay.
Yeah, I'm there. I'm here.
Okay. So we're going to open the floor. We're going to open the floor.
Your voice is echoing.
Oh, yeah. Sorry. What's wrong?
Rafi, do you want to go through some of the questions in the chat box? Because there was quite a few.
Yes, there's quite a few questions.
Why don't you just throw that at Michael, because Afsanapa's phone is echoing. We can get it started, okay?
Yes, sure.
And we're going to extend it by another 5-10 minutes to allow some of the questions to be covered. Thank you.
Okay, sure.
Is it still echoing, Sabina?
Yes, yes.
Still echoing.
So we might just have you look pretty and watch us, because I think it's because you're doing it through your phone. But let's start with questions to Michael. Rafi, could you just start, please, and share?
Yes, sure, I'll start. Michael, there was a lot of questions that we had, so thank you everyone that have written their questions to us. But we've grouped the questions up so we can get a few answers. So first of all, I think we should, since this is Bangladesh, there's a lot of questions that we have about Bangladesh. So one of the first things that that has been asked is, what are the 3 key strategies that Bangladesh can take to limit transmission?
So that's a very good question. And you know, the truth is we don't know the exact answer to that. But I would say quickly that, you know, in terms of transmission, the challenge is that we have this intense need to at least generate some economic activity in the country, right? So because people have to be able to live and have food and others income and generate the productivity of the country needs to go on. And so in that context, you know, we have to think about what are those interventions that are going to be effective that allow people still to go to work, but also stop the disease from spreading so much. And that's a real challenging question. So the answer that I would give would be, number 1, we really need to think about transportation issues, right? Getting on crowded buses, crowded trains, things like that are going to be a recipe for disaster. We really need to really think about how to manage people's transportation. And I don't know the exact answer to that, but we have to kind of come up with some creative solutions that how people can get around to their jobs or wherever they need to get around to without getting onto these crowded places and risking their own health. Number 2, I think we need to think about places of worship. Okay, place of worship is a very common place here for people to get together. And this has been true in other countries where we've had very large outbreaks due to churches and due to other you know, activities, synagogues, other things too. So here, I think, you know, we have to really think about what our strategy should be, you know, with mosques and how can we allow people to go to the mosque, but still really protect people. That's a real challenging issue. And then the third area to focus on would be, I think, within the workplace, you know, so when people do go to work, how do we create an environment within the workplace that allows people to have some social distancing, some hygiene, some ability to screen those that are sick. So if we can do those 3 things, I think that will have a major dent. So I'll stop here.
Now, Dr. Friedman, you mentioned the 3 key strategies, and we have another question here. It says that in a country like Bangladesh, where informal economic sector is holding the lion's share, should we focus on limiting the transmission, or should we focus on resuming economic activity? And it might cost us to sacrifice some lives, but if the economy crashes, we're going to be in a big, even bigger crisis.
Okay,
So,
Rafi, can I come in with another question? I was going to group a few questions together. There's a couple of questions around, is there any scientific reason why fatality rates among males are higher than females? And pregnant women who might have COVID, and how would they manage newborn and breastfeeding? If there's any information around that, is what I saw as well. I just wanted to group some questions together. Thanks.
Okay, so let me take the first one. The first one's a big question, and that's a hugely complicated question. And obviously, at the end of the day, that's left up to, you know, the key leadership of the country to make those decisions in terms of when to open things up or to what degree we should open up and what's our risk versus benefit balance. You know, from my perspective as a public health, you know, official in the U.S. and you know, someone who's dealt with different diseases over time, is that, you know, we need to be holistic about this and understand and balance these things. There are a large number of public health risks in the world that still exist today. I think we'll progress on a lot of these areas, but COVID is obviously another example of this. And with each disease that we tackle, we have to do this kind of calculation, like which disease should we focus on, which one should we invest in, which one should we, you know, take seriously, and which ones do we not take as seriously. And that's a very challenging, process to kind of go through. For this disease, it's a serious issue. We definitely need to take it seriously. But are we going to have to, in a country like Bangladesh, make some sacrifice, some degree of sacrificing control in order to allow other diseases to be taken care of, or to allow people to, have some economic and social opportunities? Yeah, I think we're going to have some balance here. I think that we can't go into this saying that the only thing that matters is controlling COVID. We have to think about this in terms of responding to this crisis in the context of everything else that's important to Bangladesh, and that's a tough decision. So I'm not going to give an exact answer on that, because it's not my place to give that, but it's a complicated process to try to figure that out. And if we had better treatments, then the answer would be easier. Then you could say, yeah, let people get sick because we have treatments, or let people get infected because then we can treat them. But without treatment, it's a little more complicated. As to the other questions, we don't really know why men are getting it or getting sicker than females are. One possibility is that men have more comorbidities. They're more likely to be obese. They're more likely to have hypertension, other diabetes. That could be part of the reason. It also might be something about there are some suggestions that it might be to do with hormone levels and other things too. We don't know. We just don't know. We don't have any evidence of that. So I would say the jury is still out on why males tend to be a little bit sicker than females, but we know males don't live as long as females too in general. So we know that there are genetic differences, there are gender differences in a lot of different diseases and issues. In terms of the issue about pregnancy and lactating and things like that, I don't really know the latest information on that. I know that newborn babies can get the disease. How they gotten the disease is not really clear to me in terms of whether they got it by close contact or through breast milk or some other. I'm not sure. We do know that most children, young adults, and even newborn babies that have gotten the disease have done well. Obviously, there are stories out there where that's not necessarily true, but I think in general, the disease is not as risky among pediatric populations. So I'll stop there in terms of those questions.
Okay, thank you so much. There's a few other questions. Let me just group them up. One is, what should we do at an individual level after the lockdown is lifted and everything is lifted when we're open to be cautious about COVID-19 until we get a working vaccine?
Ooh, good question. I mean, I'm asking myself the same question, right? We all are. And I would say that the answer would be that we should be careful, because just because the lockdown ended does not mean the risk has ended, right? So we need to be very aware of that. We're ending the lockdown because of economic necessity, not because the disease is fully controlled. And so we need to practice good hygiene. Good hand hygiene. Every time you go out, you should be washing your hands frequently. You should carry alcohol gel with you if you can afford it and you have it, or you should be washing your hands as much as possible. The challenge with washing your hands in Bangladesh is that there are not a lot of places to wash your hands. So we have to really do a better job of creating hand washing stations for people. But the temporary solution to that is to carry alcohol gel. Second thing is the mask, right? I got my mask here. Every time we go out in public, if it's a place where you cannot control away from other people, then you should be wearing a mask. So if you go to a park and there's only 5 people in the park and you can separate, then you don't need to wear a mask. But if you're going to a market and people are shopping and everyone's around you and everything like that, and you have no control over where people are going, then you definitely should be wearing a mask. So those are the two things that I think that are probably the most important things to do, those two things.
Michael, there's two quick questions. Sorry, Rafi, I'm coming in here. One is about, do we know the efficacy of rapid test instead of PCR? And, you know, this whole thing about central air conditioning spreading the virus. It'd just be good to kind of find out what the realities are, the truths of what you've heard.
So in terms of the rapid test, this is a very good question. And the short answer is we do not know yet. So we have not globally, and certainly in Bangladesh as well, we have not done enough studies and enough understanding of these rapid tests to know how effective they really are and what's the best way to use them. So we do believe, or well, I shouldn't say we believe, but we hope there is a place for rapid tests in the overall scope of our response. Rapid tests are so much easier to use than sending a specimen to a laboratory and doing a PCR test. However, we need to study them better, and we need to understand what the sensitivity, specificity of the tests are at different time frames in the infection. So we may find out, for example, that doing a rapid test is very poor in the first 4 or 5 days of illness, that it's not nearly as good as doing a PCR test. But we may also find out that after day 7, a rapid test might be just as effective as a PCR. So we might find out that there are certain situations when a rapid test is fine, and then maybe we may find out that there are certain situations where we still prefer the PCR testing. But right now the answer is we don't know, and CDC is, as some of you maybe have seen in the newspapers, we are interested in understanding this and validating and understanding tests, and that's one of our objectives here, not only in Bangladesh but globally, is that we are very interested in using technology and understanding their use. And so to do that, we have to study them scientifically, and we're here to help with that process. The air conditioning.
So we have another question.
But I would say that air conditioning, central air conditioning is very unlikely to spread the disease, based on the fact that this virus has been going on for 2+ months, and we don't have a lot of examples where mass number of people have gotten sick from being in a central air conditioning place. So I would say the answer to that is most likely central air conditioning is fine, but I can't say 100%.
Okay. Rafi, should we have time for 2 more questions maybe?
Yes, there's 2 more questions. There's one question that came up. Yeah, we have time for 2 more questions, but there's this one question that a lot of people are asking, which is, can you please explain exactly what this virus does to the body and the immune system? Because a lot of people are not clear on what the symptoms are and actually how the virus actually works. And also, what is a typical recovery time for the coronavirus disease? If you do get it, how long do you think it would take for you to recover?
So I'll answer the second one first because it's easier. If you have very mild disease, or you're an asymptomatic case, the evidence so far is that you recover pretty quickly, and you stop shedding the virus probably within a week. Okay, it may be variable by the person, but that's the general feeling. If you had severe disease, you ended up with pneumonia, you ended up in the hospital, then it can take many, many weeks for you to stop shedding the virus. So these are really kind of 2 different situations in terms of how long it takes before you clear it. But every case could be different. We also, just to be clear on this, when we test you with a PCR, we're looking for microscopic evidence of the virus in the sample. It does not necessarily, if your test comes back positive and you have the disease and you're trying to figure out whether or not you're still contagious or not, having those particles does not necessarily mean you're still contagious, because that just means you have the viral particles in your throat or in your nose. It doesn't necessarily mean that those viruses are still contagious. So that's a separate issue. And in fact, in some studies, when we find people a week or 2 weeks into their illness, and we find that their PCR test is still positive, when we try to culture the virus, we can't culture the virus, which means that the virus is no longer effective. So, you know, that's something to think about. The last other question you had was about, sorry?
It was about what does it do to your immune system?
Oh yeah, the questions about the immune system. So this is another complicated issue that we don't really fully understand. But basically, like many illnesses, there's two issues. There's the direct viral virus and how it damages our body. And then there's the immune response that's created because of the virus that can also damage our own body, right? So this disease has a little bit of both. The virus itself could cause some damage to your lungs and to your body, but really what we're finding so far is that most of the damage that seems to be done is that your body overreacts to the virus. You know, really has a very strong reaction to the virus, and therefore when it tries to kill the virus and get rid of it in your system, it's also killing some of the good cells in your body. It's damaging your lung tissue, it's damaging your blood vessels, it's damaging your kidneys. So that we think is some of the issue that's going on here. So this is both a issue with the virus causing damage early, and then later on in the illness, it appears that it's more about an immune response. It means that the immune response has gone overboard. And so there's both of that, it seems to be happening.
Okay, thank you so much, Dr. Friedman, for answering all the questions we have. Unfortunately, we're out of time, so we were not able to take all the questions, but we really appreciate all the questions people had asked. But Dr. Friedman, I was wondering if it would be okay if colleagues on this call could contact you directly if they have any other questions, specific questions, if that would be okay with you, if they could contact you. Do you think that would be okay?
Sure. We would be happy to try to, I mean, you know, we're obviously very busy, so we won't maybe be able to get to every question that people have. But if there's, you know, specific issues, especially if they're very practical questions that you're dealing with in your own organization or your own, you know, work, if you're working as a medical doctor or others in the field and you have questions that, you know, we're very happy to help in those situations, especially because, you know, those that are out on the front line serving the communities and trying to help people who are sick, we really appreciate that. And it's, you know, it's hugely important work. And so anything we can do to help answer some of your questions, we're here to do that.
Thank you so much. So with that, I guess we will finish our webinar for today.
I wanted to also apologize because I know you joined.
Okay, so yeah, but I just wanted to say a few words.
Yes, please continue.
Okay, so I think what actually Michael Friedman said is quite important for the country to learn, especially about the preparedness. And he particularly focused on the preparedness for this, which is the key. And secondly, the speed and surge that actually helped the health system to be prepared, especially the hospitals and others. And the third thing is that innovations. And I feel that we need to remember this because we need to feed into the public, our public policy decision makers, that if we don't do these things, I think it is not only affecting due to the COVID-19, Michael is always mentioning about other diseases. So we cannot forget the other diseases because we need to be prepared for everything, and the health system should be prepared not only to address the public health measures, even to treat the patients who are actually getting infected. So I'm quite glad to learn about all those things, Michael. It's really helpful. Thank you so much.
Great. Well, thank you. Thanks, everyone.
Thank you, Michael. Okay, thank you very much.
Thank you.
Rafi.
Thank you, everyone, for joining in, and hope to see you all again when we have more webinars in the future. So thank you, everyone. Thank you to Dr. Michael Friedman. Thank you to Professor Kaustaf and everyone else that have joined us today. Thank you very much.
Thank you.
Thank you.